Welcome everyone. This is Dr. Vaibhav, and today we will be discussing another short topic, that is fracture. How to describe a fracture in FRCR shorts examination, and the basic idea is to secure 5 out of 5 in fractures. Okay. So without delaying anymore, we'll go on to how to attempt on scoring 5 out of 5 in FRCR shorts exam. So before going to the fractures, there are actually three projectional views that we should be knowing of. First is frontal, oblique, and lateral. The three views you should know, and how to describe it if you see any fracture. Okay. Similarly, in case of hand X-rays, there are three views: frontal, oblique, and again lateral. Okay. So this is how you are going to describe fracture in your final FRCR to be shorts part of examination. So in findings, you need to describe what is the type of fracture, then where is the location of fracture, whether there is any displacement, whether there is any angulation, what type of angulation is it, whether there is articular surface involvement. We'll discuss why we are calling it as articular surface involvement and not joint involvement. Then associated periosteal reaction, yes or no. Is there any callus formation, yes or no. Is there any soft tissue swelling, and then give a brief impression. What kind of fracture you are saying, and where is the fracture located. And in the management, then we are going to discuss what you need to write. Okay. So coming to the types of fractures first. In types of fractures, we are dealing with three kinds of fractures. First is incomplete, second is Salter-Harris fracture, and third is complete fracture. So we will go step by step. First, we will be discussing incomplete type of fractures. What are the incomplete type of fractures? So what is incomplete type of fracture first? So the cortex is not completely broken. Okay, and it is commonly seen in pediatric age group because the bones are malleable. So there are three kinds of incomplete fracture. First is just a bowing fracture, second is buccal fracture, and third is green stick fracture. You should be knowing how to differentiate buccal fracture from green stick fractures. Bowing fractures is simply a bend in the bone due to plastic deformation because of the malleable nature of the bones in pediatric skeleton. Okay, you won't be seeing any cortical breaks as far as the bowing fracture is concerned. Second is buccal fracture. So what is buccal fracture? When the compression is applied on the concave surface of the bone, you will see a cortical buckling over there. Okay, then you call it a buccal fracture. Now coming to the last one, what is green stick fracture? So green stick fracture, the break is happening on the convex surface of the bones. Okay, so we'll discuss this one by one. So coming to the bowing fracture first. So bowing fracture, as we had discussed, is a plastic deformation of the pediatric skeleton because of the malleable nature of the bones, and you won't be seeing any cortical break. So this is how the normal bone will appear like, and in bowing, you will only see some bowing deformity of the bone. There might be any associated pain in that particular region, and you will not see any broken cortex. Okay, if you are not seeing any broken cortex, if there is any history of trauma, and if you see there is a bowing deformity of the bone, then you can raise a possibility of bowing fracture. Okay, so how it will appear on the cross section? If you apply pressure from the convex side, there will be tension on the convex side, and you will get this bowing deformity. Okay, so this is how the radiographic appearance will look like. You will see there is bowing along the lateral aspect. You won't be seeing any cortical break. The cortex will be intact. Okay, so what are the key points? Basically seen only in pediatric age group, not in adult age group. Results from bending or forces causing plastic deformation. You will not be seeing any break in the cortex, and the healing will be rapid in such cases. Okay, typical location, you will be seeing this in majority in the radius ulna and also in tibia fibula. Okay, now bowing fracture is done. Now we'll move on to buccal fracture, also known as torus fracture. Like we have discussed, there is a break in the cortex on the when you apply pressure on the concave side of the bone. Okay, there will slide be buckling of the cortex. Okay, buccal fracture, compression fracture, here is the normal appearance of the bone. If you apply pressure on the concave side, you will see buckling of the cortex. So this is the buckling of the cortex, right? So concave side, if you are apply pressure, you will see buckling of the cortex. On the convex side, you will not see any cortical break or any cortical buckling. Okay, usually seen in at most commonly seen at the distal ends of radius and ulna, where there is a concave side, when you apply pressure over there, you'll see slight buckling deformity. See over here, this is the most commonly seen buccal fracture in pediatric age group skeleton. Okay, uh, incomplete, these buccal fractures are also known as incomplete fractures due to axial compression. There will be cortical buckling on the concave side. Okay, on the concave side, you should be knowing, and the convex surface is intact. There is no displacement commonly seen in pediatric age group skeleton, and is a stable fracture with excellent prognosis. Okay, typical locations like we have discussed: distal end of radius and ulna, distal end of fibula, and it happens because of the compression injury on a concave side of the bone. Okay, so buccal fracture, also known as torus fracture, buccal fracture is done. We'll move on to the last type of incomplete fractures in the pediatric age group skeleton, that is a green stick fracture. So what is green stick fracture? Basically, this is also an incomplete fracture with disruption of cortex on the convex side. We have discussed that in buccal fracture there is a buckling, there is a disruption of cortex on a concave side. Okay, in the green stick fracture there is a disruption of cortex on a convex side of the bone. Okay, so this is how the normal bone will look like. In a green stick fracture, you see there is a buckling of cortex on a convex side of the bone, not on the concave side. Okay, so if you apply tension on the one side, there will be a break. Okay, compression on the opposite side, there will be bend. Okay, this is the cross sectional appearance. If you apply pressure on the convex side, there will be a break in the cortex. So you will label it as a green stick fracture. Okay, so here you can see there is a fracture on the convex side of the bone. This is the concave side of the bone, this is the convex side of the bone. So there is a fracture on the convex side. Okay, here also you can see there is a tiny fracture. I know it is difficult to see on a lateral radiograph because of the nature of the image. The image is not very high definition, that's why it is not very well seen. So as you should be knowing that the green stick fractures are an incomplete fracture. Only one part of bone is broken, that is on the convex side of the bone. Okay, then we have discussed this in the pediatric age group skeleton. Again, green stick fractures also show a good healing potential and excellent prognosis. Typical locations happen in the radius and ulna, and also in the tibia fibula. Okay, now we are done with incomplete fractures. Now we'll move on to the complete fractures. Okay, incomplete fracture, that means both the cortices are broken. Okay, so what are the complete fractures? Complete fractures are basically the break extends through the complete thickness of the bone, separating it into two or more pieces. Okay, both the cortices are involved, the concave side as well as the convex side. So what are the types of complete fractures? So there are four types of complete fractures we should be knowing of. First is transverse fracture, another is oblique fracture, third is spiral fracture, and fourth is comminuted fracture. So what is transverse fracture? Basically the fracture line runs straight across the bone, roughly perpendicular to its long axis. Okay, whenever we will see the images, okay, then you will be able to understand it in much better way. What is oblique fracture? So oblique fracture line crosses the bone at an angle rather than a straight line. It is also mentioned in few literatures that you call it as oblique fracture when the fracture line is making 30-degree angulation with the long axis of the bone. Then you label it as an oblique fracture. Why are we discussing these types of fractures? Because in order to secure 5 out of 5 in examination. Okay, also if you describe the fracture in more detail, as far as your FRCR to be Viva is concerned, then obviously you are going to get extra marks. You are going to get clear, pass, and excellent in your final FRCR to be Viva. So what is spiral fracture? Spiral fracture is twisting force creates a helical corkscrew like fracture line that wraps around the bone. We will see how the spiral fracture looks like. Then comminuted fracture, where the bone is broken into 3 or more pieces, okay, or often from higher energy trauma. Now coming to the first, so we will discuss this in more detail. Now we are going to discuss transverse fracture. So what is transverse fracture? A fracture line that runs perpendicular to the long axis of the bone. This is the long axis of the bone. This is a normal bone. Normal bone. In a transverse fracture, the fracture line runs perpendicular to the long axis of the bone, and there is a break of both the cortices. Okay. On cross sectional, you can see there is break of both the cortices. On the radiographic appearance, you can see there is break, both medial side and the lateral side of the bone is broken, and on the lateral view both cortices are broken. Okay, so what are the key features of the transverse fracture? The fracture line is almost perpendicular to the long axis of the bone. Both the cortices are broken, caused by direct blow or bending force. Maybe displaced or non-displaced. We are going to discuss this later in this lecture. Common in all age group. Okay, typical location: radius ulna, tibia, fibula, femur, and humerus. Okay, cortical. What you should be knowing about transverse fracture? That the break is happening perpendicular to the long axis of the bone, and it should involve both the cortices. Okay. Now transverse fracture is done. We will move on to oblique fracture. So what is oblique fracture? Like we discussed, the fracture line in majority of the cases should form 30-degree angulation to the long axis of the bone. Okay, this is how the oblique fracture will look like. And on radiographic appearance, both on frontal radiograph and lateral radiograph, you will be seeing oblique fracture. Okay, then if you see the fracture line is running across the bone and causing break of both the cortices and forming almost 30-degree angulation, then you label it as an oblique fracture. Okay, what are the key features? We have discussed this. Obliquely should be running across the long axis of the bone, involving both the cortices, caused by bending force with some rotational component, and tends to be more stable than transverse fracture but less stable than spiral fractures. We are going to discuss this later in the later part of the lecture. So what are the typical locations? Radius ulna, tibia, fibula, femur, and humerus. Now we'll move on to spiral fracture. So what is spiral fracture? Where the fracture line that runs spirally around the long axis of the bone. So this is how the fracture line should run. This is running spirally. So you might be seeing 2 or 3 fractures. Okay, and this is how the radiographic appearance looks like. So here, if you see on the lateral radiograph, the fracture line is running spirally. Okay, so we have discussed this. Both the cortices should be broken, caused by twisting rotational force. That you should be knowing. The spiral fractures are usually caused by the rotational twisting force on a fixed distal aspect of the bone, such as foot, and basically it is a torsion kind of injury, commonly seen in sports athletes, and also in road traffic accidents. Is associated with a significant amount of soft tissue injury, and common in adolescent and young age group. Okay, common locations are mid portion of tibia, fibula, femur, humerus, and radius and ulna. Now we are moving to the comminuted type of a complete fracture. So this is a kind of complete fracture where the bone is broken into 3 or more pieces. Okay, so if you see a fracture line and if you see there are bony fragments 3 or more in number, then you label it as comminuted fracture. So if you see this is a comminuted fracture, multiple fractures line, you can see almost 6-7 parts of the bony pieces. So that is the reason we are labeling it as a comminuted fracture. This is how the frontal and lateral projection will look like. What are the key features? So bone is broken into 3 or more pieces. This is a complete fracture. Both the cortices should be involved, caused by high energy trauma. Okay, such as road traffic accident, fall from heights, crush injury, gunshot injuries, often associated with soft tissue injury, significant amount of soft tissue injury, and may be associated with neurovascular injury. Okay, less stable and has higher risk of complications. Typical locations: mid portion of tibia, fibula, femur, humerus, and radius and ulna. So bone is actually shattered into multiple pieces. That is how you are going to remember comminuted fracture. Okay. Now coming to the last kind of fracture, that is Salter-Harris fracture. Salter-Harris fractures are important as far as pediatric age group is concerned, and even in your FRCR shorts kind of examination, you need to describe Salter-Harris fracture in detail, and you need to also mention what kind of Salter-Harris fracture are you dealing with. Is it type 2, type 3 or type 4? So we should be knowing how to differentiate Salter-Harris fracture one from another. Okay, so what is Salter-Harris fracture? A fracture which involves the growth plate. Okay, so growth plate will only happen in pediatric age group, so that is the reason Salter-Harris fractures are only seen in pediatric age group skeleton. If you see adult skeleton, then don't label it as a Salter-Harris kind of fracture. Salter-Harris kind of fractures are only seen in pediatric age group skeleton. Now what is there are 5 types of Salter-Harris fracture you should be knowing. So Salter-Harris kind of type of fracture 1, that is running, the fracture line runs straight through the growth plate through the physis. Okay, there is no involvement of epiphysis or metaphysis in Salter-Harris type 1. Coming to Salter-Harris type 2, Salter-Harris type 2, the fracture line involves growth plate, that is physis, and also involves metaphysis. Okay, Salter-Harris type 2 fractures involves growth plate and metaphysis, adjacent metaphysis. The epiphysis is spared. Okay, coming to Salter-Harris type 3, so the fracture line involves growth plate, physis, and adjacent epiphysis. There is no involvement of metaphysis. Salter-Harris kind of type 4 fracture, it involves all the 3 parts, metaphysis, growth plate, and epiphysis. Coming to last type of Salter-Harris fracture, that is Salter-Harris type fracture 5, it is basically a crush injury of physis. Okay, caused by a compression injury, and usually on initial radiographs it is difficult to appreciate, but we will see how to identify Salter-Harris various kinds of Salter-Harris type fractures. Okay, now coming to Salter-Harris type 1 fracture first. So here in Salter-Harris type 1 fracture, basically the fracture is running through physis, through the growth plate only. There is no involvement of metaphysis and epiphysis. Like in this Salter-Harris type 1 fracture, you can see the fracture line is only running across the physis. There is no involvement of metaphysis as well as epiphysis. Okay, or how will you see, how will you identify Salter-Harris type 1 fracture? You will see subtle widening at the growth plate. Okay, if you see there is subtle widening of the growth plate, then you label it as Salter-Harris kind type of 1 fracture. Usually it is difficult to identify, but if you see any associated soft tissue swelling at this location and subtle widening of the growth plate as compared to the adjacent growth plate, then you label it as Salter-Harris type 1 fracture. So what are key points? So fracture runs only across the growth plate. Okay, there is no involvement of metaphysis and epiphysis. Difficult to identify on X-ray, but if patient has significant pain with associated adjacent soft tissue swelling, then you can raise a possibility of Salter-Harris type 1 fracture. Commonly seen in pediatric age group skeleton. Prognosis is excellent. Okay, what are the typical locations? Usually seen at the distal end of femur, distal end of tibia, also distal end of radius and ulna. Okay, now coming to Salter-Harris type 2 fracture. So what is Salter-Harris type 2 fracture? Like we have discussed, the fracture line that runs across the growth plate and adjacent metaphysis. Okay, epiphysis is spared in Salter-Harris type 2 fracture. So if you see, this is the fracture line. The fracture line is running across the growth plate and extending into metaphysis. This is metaphysis. The epiphysis is spared. This is Salter-Harris type 2 fracture. And as you can see there is a fracture line. There is uncovering of this growth plate. That means the fracture line is running across the growth plate and extending along the dorsum aspect of the radius. That is why your this bony fragment of the distal end of the metaphysis is separated from the parent bone. So this is Salter-Harris type 2 fracture. Okay, so in this Salter-Harris type 2 fracture, epiphysis is usually spared. And you should remember Salter-Harris type 2 fracture is a most common type of Salter-Harris fracture. Okay, associated with can be associated with mild displacement. Prognosis is excellent. Commonly seen in at the distal end of femur, distal end of tibia, radius, ulna. Now coming to Salter-Harris type 3 fracture. Okay, what are Salter-Harris type 3 fractures? So this is second most common type of Salter-Harris fracture. Type 2 was most common, type 3 is second most common. So what happens in Salter-Harris type 3 fracture? The fracture line runs through the growth plate and involve adjacent epiphysis. The metaphysis is spared. This is how the Salter-Harris type 3 fracture will look like on schematic representation. This is the fracture line running across the growth plate and then extending into epiphysis. Okay, and this is how Salter-Harris type 3 fracture will look like. If you see, the fracture line is running across the growth plate and there is extension into the adjacent epiphysis. So this is Salter-Harris type 3 fracture. You should remember that Salter-Harris type 3 fracture, the metaphysis is not involved, and it may or may not be associated with displacement of the epiphysis. Okay, the prognosis in Salter-Harris type 3 fracture, if the displacement is not there, then prognosis is excellent, usually seen at distal end of tibia and distal end of fibula. Okay, coming to Salter-Harris type 4 fractures. So Salter-Harris type 4 fractures are basically the fracture line runs from metaphysis across the growth plate and into the epiphysis. So all three parts of the bones are involved. So that is the reason this is Salter-Harris type 4 fracture. On the radiograph, you can see the fracture line is running across the metaphysis, then into physis, and then into epiphysis, and reaching up to the articular surface of the distal end of tibia. Okay, this is less common type of Salter-Harris fracture, and usually this is slightly of higher risk of having growth disturbances in the growing skeleton as compared to type 1, 2, 3. Okay, prognosis is good if there is no significant displacement and if there is good reduction. Okay, now coming to the Salter-Harris type 5 fracture. So Salter-Harris type 5 fracture is basically a physeal compression. If you see over here, the growth plate is not very well seen, so there is compression injury at the level of growth plate. There might be associated shortening of the length of the bone, and on the radiograph you can see the growth plate is seen at the level of fibula, but when if you see the growth plate of the tibia, the growth plate is not seen. Usually in most of the cases the fracture line is not seen. You will only see there is reduction in the height of the growth plate and associated soft tissue injury. This is how you are going to identify Salter-Harris type 5 fractures. So this is a physeal compression injury without any fracture line caused by high energy axial loading. Okay, usually on the radiograph it is difficult to pick up Salter-Harris type 5 fracture. It has a highest risk of growth arrest, growth disturbances amongst all the Salter-Harris type fractures. Diagnosis may require clinical suspicion and follow-up imaging. Prognosis is guarded, and growth plate, you should monitor a growth plate in such cases. Okay, now coming to this, we are done with type of fractures. Now rest of the parts are easy. Now coming to the location of fracture, where in the bone you have to locate where is the fracture line, and you have to describe it properly, whether the fracture is seen only in the epiphysis, metaphysis, or diaphysis, and which terminologies to be used in various kinds of fractures. Okay, coming to the fracture location. So which part of the bone is affected, we should be knowing. So there are three parts of the bone: epiphysis, metaphysis, and diaphysis. What is epiphysis? Epiphysis is basically the ends of the bones. Okay, metaphysis is basically when the epiphysis widens up and forms a part of the bone, that is known as a metaphysis, and it is usually located adjacent to the growth plate. And diaphysis is the shaft of the bone. This is how you are going to locate and mention which part of the bone is involved. The schematic, this is a schematic diagram of the bone. This is for your better understanding. So this is the ends of the bone, like we have discussed. These are known as epiphysis. The epiphysis, before turning into diaphysis, that the flaring portion of the bone, the widening portion of the bone is known as metaphysis, and the middle portion of the bone is known as diaphysis. Okay, when it comes to long bones, we have to describe the bone in this particular using these terminologies, epiphysis, metaphysis, and diaphysis. This is the diaphyseal shaft fracture, this is the metaphyseal fracture, and this is the epiphyseal fractures. Okay, now coming to the metacarpals. Okay, when you see metacarpal fractures, then the terminologies are slightly different. In metacarpals, there are four parts of the bone, that is head, neck, shaft, and the base. Okay, you should be knowing, as far as the metacarpals are concerned, you can describe the fractures using these terminologies: head, neck. So this will be head, this will be neck, this is the shaft of the metacarpal bone, and this is the base of the metacarpal bone. Okay, now the location is done. Now we'll move on to displacement and angulation. When do you call displacement, how to describe displacement, and which fracture you have to mention this is an angulated fracture, and which angulation you should be use. Okay, you should be using whether it is a ventral apex angulation or dorsal apex angulation, you should be knowing which terminologies to be used. Okay, so in fracture displacement, you should know how the broken bone fragments have moved from their normal alignment. It is usually described by the position of distal fragment relative to the proximal fragment. Okay, so as far as the fracture displacement is concerned, there are four ways in which you can describe fracture displacement. First is angulation, second is translation, third is diffraction, fourth is rotation, and fifth is impaction. So these are very easy to understand because the heading of the fracture displacement is like that. Angulation means there must be some angulation at the fracture site. Translation means the one part of the bone must be displaced anteriorly or posteriorly, that is known as translation, when the fractured fragments are shifted sideways. Okay, diffraction means at the fracture side the bones are pulled apart. Rotation means we are going to see how the rotation means one part of the fractured bone is rotated along the long axis, and how to identify whether there is a rotational fracture or not, and how to identify impaction fractures. Okay, now we are going to discuss one by one, coming to the angulation part first. So angulation, we are going to mention angulation separately in while we are describing fracture, because if the fracture is angulated, then that is the situation where the orthopedicians are going to fix the bone. Okay, whenever they see any angulated fractures, that is a surgical candidate for them. So if you see bend in the bone that causes angulation at the site of fracture, then you have to label it as angulated fractures. Okay, so here both you can see there are complete fractures, transverse fractures at the distal metadiaphyseal portion of the radius and ulna, and here this is the medial portion, this is the medial aspect, medial side, this is the lateral side, and I would say that there is a medial apex angulation of both the fractures, right? More on the radial side. Now coming to the lateral view, on the lateral view, there is a ventral apex angulation. Okay, this is the palmar side, this is the dorsal side. You see there is a ventral apex angulation. So you need to describe the angulation both in frontal radiograph as well as lateral radiograph. So if a bending force is applied to the bone, the cortex on convex side is compressed while the cortex on the concave side is straight. Okay, and you will see such angulation deformities in the bones. Okay, how to measure angulation? You draw a perpendicular long axis along the proximal fractured end, and long axis along the distal fractured end, and whatever fracture line you can the angle is forming with this in between the two lines, that you have to mention it in the report. Okay, the smaller the angle, you have to measure a smaller angle, not a bigger angle. Okay, and yeah, this we have discussed. And the types of angulation, right? We have discussed ventral apex, dorsal apex, medial apex, lateral apex type of angulation. You have to mention it in your report. Okay, yeah. So angulation fracture is done. Now we'll move on to the translational kind of fractures. So these are On frontal lateral radiograph, you can see there are fractures involving distal diaphysis of the radius and ulna, and you can see there is a lateral display. There is a, sorry, you have to always mention in terms of the distal fragment bone. Okay, so there is medial displacement of the distal fragment, distal fractured portion of both radius and ulna. And coming to the lateral radiograph, you can see there is a dorsal displacement of radius as well as ulna, dorsal translation. Okay, now translation occurs when the distal bone fragment is displaced horizontally or vertically relative to the proximal fragment. We have discussed this, and this is the type of translation fractures. You have to mention it in the report. This is the lateral translation. So this is the proximal end, this is the distal end of the fractured bone, this is lateral translation, this is the medial translation. Now on the lateral radiograph, on lateral view, how are you going to mention? If this is a distal fragment, then this is a anterior translation, and this is a posterior translation on the lateral view. Okay, you have to always mention translation in accordance with distal fractured bony segment. Okay, measuring translation, so measure side by side. Some people also write this as half width medial translation, okay, of the distal diaphysis of the left radius, half width. This is 3/4 width lateral medial translation. This is full width dorsal translation. This is also full width dorsal translation. Okay, this is how you are going to describe it. What are the clinical relevances of translation? Mentioning translation because if there is significant translation, then can affect fracture stability and healing, and these are also the candidates for surgical treatment, surgical alignment, surgical fixation of the fracture. Okay, may require reduction to restore alignment and important for treatment planning and monitor healing. Okay, coming to the rotation. So rotational fractures are important, but in order to mention the rotational fractures on the radiograph, the radiograph should be having proximal joint and distal joint in the exposure. Okay, now if you can see, so there is this fracture, most likely oblique fracture in the mid diaphyseal portion of left tibia and fibula, and there is rotational kind of injury at this level. We are going to discuss how. Okay, so this is lateral rotational injury. Lateral rotation, you have to mention it in terms with the distal fragment, distal bony segment. Okay, now if you are concentrate at the level of knee joint, now at the level of knee joint, it looks like the exposure is taken in the frontal projection, right? So this is a frontal projection. Now as we go down, you should be seeing tibia and fibula separately, or there might be slight overlapping. Okay, so up to this part, the normal alignment is well maintained between tibia and fibula. Coming inferiorly, you can see the talus and the calcaneus. The foot has rotated towards the outer side, right? Ideally, in frontal projection, you should be seeing in face projection of the foot. Okay, but this is not happening. This must be some athlete, so that is the reason the foot has rotated outside. So there is outside translational, outside rotational injury. Okay, this is external rotation. Had the foot seen in along the medial side, then you would have called it internal rotational fracture. Okay, understood my point? These are the schematic diagrams. If you can see, you need to have both proximal joint and distal joint in the exposure in order to comment upon how is the rotational fracture. Okay, whether it is external rotation or internal rotation. Okay, so this is external rotation. If the distal fractured bony segment has externally rotated, then you label it as external rotation. If it is internally rotated, then you label it as internal rotation. Okay, so we have discussed this, how to measure rotation. So compare the position of cortical landmarks such as tibial tuberosity or fibular head between the proximal and distal fragment. Okay, on lateral radiograph, you have to compare the cortices, compare the cortical outlines and tuberosities for the rotational alignment. Okay, what is the clinical relevance? So basically it is important, these all whenever orthopedics encounter rotational kind of fractures, all these patients are surgical candidates because they need to fix the long axis of the bone. Okay, if this is not fixed, then the patient will develop functional impairment. Even small degree of rotation can affect gait and joint mechanics. Important to identify and correct for optimum healing and function. Understood about the rotational fractures? Now coming to the distraction. So as the name suggests, so whenever there is a fracture, there is, so if the fracture is over here, this is called as distraction injury. Okay, there is displacement of both the ends of the bone away from each other. Okay, that is known as distraction fracture. So distraction fracture occurs when the distal bony fragment is pulled away from the proximal fragment. Okay, increasing the gap between them. So this is how the distraction fracture will appear like on schematic representation. So distraction fracture, there is increased gap at the site of fracture. Okay, and the distraction kind of fracture happens because of the longitudinal distraction, longitudinal pulling away forces. That is where you will have distraction kind of fractures. The distraction kind of fractures might have associated angulation, or then you label it as complex distraction. Okay, what is the clinical relevance? Distraction may indicate high energy injury and soft tissue damage. If there is a large amount of distraction, it can affect fracture healing, fracture stability, and important for treatment planning and monitoring reduction. Understood? Now coming to the last part, that is impaction kind of fracture. So what happens in impaction? So if there is a fracture, both the bones get impacted towards each other. Okay, so sometimes it is difficult to identify a fracture line in cases of impaction fractures, but impaction fractures can be identified based on the length of the bone. If the length, because of the distraction, the length of the bone will reduce in size. Okay, this is how frequently seen at the level of femoral neck fractures, and you have to compare the length of the femoral neck on the affected side towards the length of the femoral neck on the normal side. As you can see in this particular case, there is shortening of the neck of the femur on the left side as compared to the right side. That is the reason we are labeling this as a impacted kind of fracture. Okay, so impaction occurs when the distal bony fragment is driven into proximal bony fragment. Okay, so the bony fragments are driven towards each other. That is the reason there is shortening of the length of the bone. So that results into shortening of the bone along the long axis. Okay, what is the clinical relevance? Can affect the limb length and alignment. Significant impaction may influence treatment planning and prognosis. And it is important to assess any associated angulation or any deformity. Okay, if there is any associated angulation or deformity, then these patients are surgical candidates. Understood? Now moving on to the articular surface involvement, the fifth point, when to mention that there is articular surface involvement or not. So I refrain students mentioning joint surface involvement. It is always preferred to mention articular surface involvement, because sometimes you never know on the radiograph. It is difficult to identify whether there is intra-articular extension or not, because the intra-articular extension means where is the joint capsule actually attaching. Okay, on the radiograph it is difficult to see and it is difficult to demarcate what is the exact attachment of the joint capsule. So it would be better if you just mention on the radiograph whether there is joint surface extension or not. Okay, if the fracture line extends into the joint surface, obviously then there is intra-articular extension, but need not all intra-articular fractures will have joint surface involvement. Understood my point? We are going to discuss it in further slides. Okay, and this is more serious kind of fracture because it can disturb joint alignment and movement. These fractures often need more careful treatment, and surgery may be required to restore the smooth joint surface. Otherwise, such patients will have higher risk of developing arthritis in the future. Okay, so this is how the fracture, this is a fracture line extending up to the joint surface, and there is associated flattening, some depression over here, right? So in such kind of fractures are surgical candidates. The orthopedician needs to fix the broken bony fragments with each other in order to prevent arthritis happening in the future. Okay, what is the clinical significance? These fractures are at increased risk of post-traumatic arthritis, may affect joint congruity, stability, and range of motion, often requires precise reduction and stable fixation, important for surgical planning and prognosis. Okay, how to assess joint involvement? So this is how on the radiograph you have to mention if the fracture line is extending up to the joint surface. Okay, and whether there is tape off at this level or not. Here you can see there is significant tape off, there is depression and flattening at this level. Understood? So this is articular surface involvement, and this is extra articular fracture. Okay, difficult to mention, but we should not go into that in so much details. Just mention it in the radiograph whether there is any joint surface involvement or not. Understood? Now coming to the next part, that is a periosteal reaction. Do you see periosteal reaction whenever you encounter any fracture? So periosteal reaction is usually seen after 7 days. Okay, so that is the reason when the fracture is occult, or whenever there is hairline fracture difficult to see on first radiograph, we always ask the patients to get follow-up radiograph after 7 days. So that is the time when you will see periosteal reaction, and then you can identify the fracture site confidently in a follow-up radiograph. Okay, if you are not seeing any fracture and your orthopedic colleague is highly suspecting fracture, then write it in the report that follow-up x-ray is advised after 7 days, because after 7 days the periosteal reaction will develop, and periosteal reaction is your friend. So the periosteal reaction will help you to identify exact location of the fracture. So this is the fracture here right now at this point of time. Maybe we can see some faint fracture line over here, but not very confident. But since there is a significant periosteal reaction, solid kind of periosteal reaction over here, there might be a fracture at this level in the past. Okay, now coming to the callus formation, whether there is any associated callus formation or not. So this is how the callus formation will look like on the radiograph. So this is a fracture, and associated with fracture, transverse fracture, lateral apex angulation, maybe slightly translation, slight 1/4 translation towards the lateral side, and there is periosteal reaction on the lateral aspect. On the medial aspect there is periosteal reaction and some good amount of callus formation. Okay, since there is slight angulation deformity at this level, this fracture should have been corrected at the initial point, right? Now coming to the last part, that is a soft tissue swelling, whether there is any associated soft tissue swelling. Now here, this is a lateral radiograph of the finger. This is the fracture, and associated with the fracture, you see there is soft tissue swelling over here. Okay, now in the impression, whatever fracture you are seeing, you just have to write it in the impression. Now coming to the management part, so in most of the people, most of the exam going students have seen just mentioning this: urgent orthopedic referral and SOS fixation. Okay, this most of the 90% of people have seen just mentioning these points. But what the examiner's feedback is like, it is not just about orthopedic referral and fixation. You should also be knowing basic management of the fractures, where the patients are actually requiring management, and what kind of management is required. It is just a cast application or splint application, or do they really require orthopedic surgical fixation? So we need to mention all these 3-4 points in the report. First is urgent orthopedic referral, right? That anyways we are going to write it in the management. Second is analgesia, immobilization, and neurovascular assessment. Okay, neurovascular assessment is required. All the orthopedicians, whenever they encounter any fracture, first and foremost thing they are going to do, whether they feel distal pulses or not, whether the distal pulses are palpable or not. If the distal pulses are palpable, if the neurological assessment is good, if the patient is able to feel senses distally at the fracture site, then neurovascular assessment is good. Okay, If neurovascular assessment, if the orthopedician is not going to feel any pulse, then orthopedicians are going to suspect some vascular injury, and if there are no pulses, then he is going to require CT angiography of that particular limb. Okay, then the third and fourth part is important. If you are encountering some stable fractures, undisplaced fracture, then in those cases conservative management is required with cast or splint. Okay, if you see some significantly displaced fracture, unstable fractures, any intra-articular extension of the fracture, open fractures, or those fractures which are associated with neurovascular impairment, in those cases surgical fixation is required. Okay, so we are at the end of our lecture today. So we have discussed fractures in detail, and I have also given you uh, uh, the model answer. Okay, how you should be writing fractures in detail in FRCR to be shorts exam, so that you can secure 5 out of 5. I don't see any point of securing 3 out of 5 as far as the fracture part of x-rays are concerned, because at least out of 25, at least you are going to get 2 to 3 or maybe 3 to 4 fractures in the final exam. So okay, so if you are getting 3-4 fractures, you just need to copy paste this model answer and just fill in the blanks. Okay, if you can just do that, you can easily secure 4 out of 5, 5 out of 5, and try to mention all the 3 points in the management. Okay, urgent orthopedic referral, analgesia, immobilization, and neurovascular assessment, and any of the third or fourth. If the fracture is stable or undisplaced, you have to mention conservative management with cast and splint application. If the fracture is unstable, displaced, then surgical fixation is required. Okay, so this is how you are going to write it at first, and then if you encounter any other fracture in the examination, you just need to copy paste this format and just fill in the blanks. Okay, that will save your time, and also you will secure 4 out of 5 and 5 out of 5 in examination. So coming to the end, guys, thank you. Maybe the next session we are going to discuss the dislocation, how to mention dislocation in final FRCR shorts exam. This these model answers and these shorts lectures are not only going to help you in your shorts part of examination, but also going to help you in your Viva part. You should be mentioning, you should be knowing which fractures are unstable, which fractures require surgical fixation, how to measure angulation, how to measure translation, how to see whether there is rotational component is there in the fracture or not. Okay, okay, thank you guys, see you next time, bye.